Agus Surono, Ph.D. M.Sc, Specialist THT-B.K.L, Subspecialist Bronchoesophageology Consultant as the speaker, and followed by the second topic, which is the Managing Pediatric Upper Airway with Professor Wei Chung Su, MD, Ph.D. as the speaker. And this session, the seminar will be led by Dr. Paramita Wulandari, M.Sc, Specialist THT-B.K.L, Subspecialist Laryngopharyngology Consultant as the moderator. And there will also be a panel discussion that we will discuss some difficult cases. And we will have a break before we proceed to the workshop session.
And the workshop will be led by Dr. Paramita Wulandari, M.Sc, Specialist THT-B.K.L, Subspecialist Laryngopharyngology Consultant as moderator. The session will be consisted of case and real patient discussion and fiber optic laryngoscope hands-on before we proceed into the closing of today's event. Marilah kita awali acara pagi hari ini dengan bersama-sama membacakan lafal basmalah. Bismillahirrohmanirrohim.
Ladies and gentlemen, to honor our country, let us all rise and sing the national anthem of Indonesia, Indonesia Raya.
Hadirin dimohon berdiri untuk menyanyikan lagu Indonesia Raya. Para hadirin dipersilakan duduk kembali.
Thank you. Please be seated.
Selanjutnya, kita akan masuk ke pembacaan doa yang akan dipimpin oleh Dr. Faik Hilmi Yoga Ciptadi. Kepada Dr. Faik, waktu dan tempat kami persilahkan.
Assalamualaikum warahmatullahi wabarakatuh. Ladies and gentlemen, let us bow our head for a moment, pray to God Allah Subhanahu wa Ta'ala, so that our event today can be precious to all of us. I will lead this prayer based on the teaching of Islam, and those who are not Muslims, you are pleased to pray according to each of your beliefs. Alhamdulillahirabbil alamin, hamdan yuafi ni'amahu wa yukafi mazidah. Ya Rabbana lakal hamdu kama yanbaghi jalali wajhikal karimi wa azimi sultanik. Allahumma inna nas'aluka salamatan fid din wa alafiyatan fil sad wa ziyadatan fil ilmi wa barakatan fil rizqi wa taubatan qoblal maut wa rahmatan indal maut wa maghfiratan ba'dal maut. Allahumma ighfir lana wa liwalidayna walil muslimin wal muslimat wal mu'minina wal muslimat al ahya'i min amwat. Allah, today, Saturday, September 9, 2023, we gather here to bring a seminar and workshop. The theme is Diagnostic Approach on Pediatric Upper Airway. Make this seminar and workshop as a useful scientific assembly, as a medium of sharing useful ideas, knowledge, and experience of scholars, researchers, and students of various disciplines. May the conference we organize today benefit to self, broaden our knowledge, shine our ideas, and lead us to be successful persons. O Allah, guide and bless our hearts and our minds with the light of your guidance. Impart your supreme wisdom upon our activities. Make us to speak our minds clearly. Help us to listen to each other, respect each other, love each other, so that we are included to the blessed person. O Allah, protect us from unintended temptation. Show us the right path and give us knowledge and strength to perform good things. Equally, show us and make it clear the bad things and give us knowledge and strength to avoid them. O Allah, you are the one who can fulfill our dua. Rabbana atina fid dunya hasanah wa fil akhirati hasanah wa qina adzabannar. Subhana rabbika rabbil izzati amma yasifun wa salamun alal mursalin. Walhamdulillahi rabbil alamin. Amin ya rabbal alamin.
Thank you, Dr. Faik. On to the next agenda, we would like to hear some welcoming speech by the head of the Department of Ear, Nose, Throat, and Head and Neck Surgery of Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada. Dr. Agus Surono, Ph.D., M.Sc, Specialist THT-B.K.L, Subspecialist Bronchoesophagology, Consultant. The time is yours, Dr.
Oke, terima kasih. Assalamualaikum warahmatullahi wabarakatuh. Salam sehat untuk kita semua. Selamat pagi. The Honorable Professor Chung, thank you very much for your coming. This is the second time after several years ago. You visited in Jakarta in hari, only one night, and we visited the two temples in one day. Okay. And then on behalf of Department of Otolaryngology, Head and Neck Surgery, Faculty of Medicine, Public Health and Nursing, so we'd like to deeply thanks for your visiting here. Actually, this is part of collaboration between NTUH and UGM, and then especially for the visiting professor. And kemudian yang kami hormati para partisipan yang hadir secara online dan offline, terutama yang para senior ini para expert. So actually the some participants already expert, Professor Chung, except Dr. Ezi. Dr. Ezi not only expert but the most expert. So if you have any questions or comments, so please feel free to discuss. Kemudian kami menyediakan waktu kurang lebih nanti 60 menit untuk diskusi. Kami akan memancing untuk beberapa mungkin kasus-kasus yang kami temui, kasus-kasus yang sulit, sehingga nanti bisa berkembang. Dan alhamdulillah, jangan khawatir tidak ada jawaban, karena expert kami, Dr. Ezi, Dr. Zulka, pasti akan memberikan beberapa trik, ya, tips bagaimana menghadapi masalah-masalah di upper airway. Acara ini mungkin tidak hanya berlangsung hanya hari ini, karena ini merupakan bagian dari kerjasama antara UGM dan NTUH. Mungkin ada beberapa kali acara, baik secara online maupun offline, yang akan kami selenggarakan. Tidak hanya di bidang ENT, khususnya pada faring-laring, tapi juga di bidang yang lain. Saya tidak lupa menyampaikan bahwa Prof. Chung is the first professor in pediatric otolaryngology. And now he is the president of Pediatric Otolaryngology in Taiwan. And also the founder of Asian Pacific Pediatric Otolaryngology. Ya, kalau tidak ada beliau mungkin belum bisa berkembang. Nah, ini mungkin PR buat kita semua, ya, dari UGM, dari UI, kemudian dari UNAIR, bahwa kita belum sempat mengembangkan asosiasi Pediatric Otolaryngology, ya. Kita semua, mungkin kita tidak berkembang ke divisi, ya, masih jauh, tapi merupakan peminatan. Jadi bagi teman-teman yang tertarik, nanti di Jakarta juga ada beberapa acara yang berhubungan dengan pediatric airway, silakan bergabung. Mungkin suatu saat kita mendirikan organisasi, bukan divisi tapi peminatan, dan nanti akan melibatkan teman-teman lain selain dari THT. Jangan menunggu konsultan dulu, jangan menunggu fellowship dulu. Anda tertarik, silakan hadir. Ya, karena ini penting, karena kita melihat pada anak-anak itu tidak melihat sekarang, tapi melihat 20-30 tahun kemudian apabila saat ini dia menderita masalah-masalah yang berhubungan dengan airway. Dan banyak sekali misdiagnosis. Dan banyak sekali yang kita sedih adalah keterlibatan teman-teman THT yang berperan terhadap awareness pada masalah-masalah upper airway. Ya, kita kadang-kadang dilibatkan kalau sudah berat. Ya, ini merupakan tantangan kita untuk promosi ya. Saya salut ya kepada Dr. Ezi, Dr. Zulka beberapa kali sangat aktif menerima konsultanan, menerima beberapa tidak hanya di RSCM tapi di lain untuk mempromosikan bahwa kita bisa. Ya. Ya mungkin masalahnya ya alat-alat yang kurang bagus ya. Tapi saya kira Prof. Wei, so I think it is possible for everybody to visit the NTUH for the fellowship 1 or 2 months. We can see a lot of equipment you have, not like us. So jadi kita bisa melihat beberapa equipment dari Prof. Di sana. Kebetulan kami juga pernah ke sana 2 bulan bersama Dr. Rizka dari UNER. Mohon maaf kita kadang cuma ngiler lihat alatnya kok canggih-canggih ya. The latest version of the equipment available in your hospital, right? So when I attended the operation with Prof. Chung, I saw the latest version. Probably we never see that equipment, but I saw there. So make it easy. And the most important is the support from the anesthesiologist. Whatever the difficulty in the upper airway, the anesthesiologist always supported that. So itu yang membuat kita menjadi tantangan. Masalah kita selalu sama, yaitu adalah support dari anestesi. Tapi kalau kita tidak bergerak bersama-sama, kemudian menunjukkan bahwa kita juga mempunyai kontribusi di situ, mungkin akan ada beberapa yang baik. RSCM sekarang menjadi lebih baik ya, Dr. Ezi begitu sabarnya ngemong mereka, jangan berkelahi, tapi dimong. Ya, saya banyak belajar dengan beliau, nanti mungkin beliau ada pengalaman, jangan fight dengan anestesi, tapi dimong. Ya. Kami pun juga ada masalah, beberapa teman yang di center lain juga ada masalah. Masalahnya adalah tidak adanya support dari mereka, tidak ada keberanian. Ya. Kalau kita lihat waktu di Singapura, India itu anestesi putri-putri itu apapun masalahnya, selama kita ingin mereka bius. Kok bisa ya, kita waktu itu sampai yang dari Indonesia kok bisa ya mereka itu membius pasien-pasien yang dalam tanda petik sebenarnya risiko tinggi ya, tapi mereka berhasil. Nah di kita sebelum membius sudah takut duluan. Nah inilah nanti kita lihat trik-trik dari teman-teman RCM itu sangat luar biasa, ngemong mereka yang tadinya susah jadi bisa. Ya ini kita minta teman-teman yang hadir bisa mengembangkan bersama-sama untuk membangun kita yaitu terutama pediatrik otolaryngologi. Kita tidak ingin menjadi divisi tapi menjadi suatu kelompok studi bersama ya demi kebaikan dan harus promosi bahwa kita bisa, kita punya peran di situ. Ya mungkin itu yang bisa saya sampaikan. Terima kasih atas kehadirannya baik yang online maupun offline. So the last my question is availability for the fellowship. At least how long? 1 month, 2 months, 6 months?
Welcome anytime and any durations if you want to visit our hospital.
And no charge.
Yes.
Ya, kita tidak bayar di sana. Bayarnya tiket sama tinggal. Tapi kafenya murah. Jadi di lantai bawah, the basement of the hospital, there food court. It's not so expensive dan ada halal food. Ada halal food. Dan rumah sakit yang baru itu di lantai 7 ada praying room. Jadi kita bisa sholat di sana, kemudian bersama dengan teman-teman yang lain. Nggak masalah, tempatnya sangat bersih dan mereka sangat welcome. Ya, makanya kalau hanya seminggu 2 minggu saya pikir kurang ya. Kalau bisa 1 month or 2 months. Nah, dari beberapa teman di Malaysia mereka memaksa untuk 6 bulan harus fellow di sana. Mereka nggak masalah karena gajinya tetap. Di kita kalau nggak praktek yang gajinya nggak ada. Itu aja bedanya. Sangat kecil tapi sangat penting bagi kita. Ya terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Thank you so much, Dr. Agus Surono, for the kind remarks.
Hadirin sekalian, berikutnya kita akan memasuki acara seminar yang akan dipimpin oleh Dr. Dian Paramita Wulandari, spesialis THT-B.K.L subspesialis laringofaringologi konsultan.
Dr. Dian Paramita is a laryngopharyngologist and a lecturer in the Department of ENT, Faculty of Medicine, Public Health and Nursing of Universitas Gadjah Mada. She finished her specialistic study in Universitas Gadjah Mada and fellowship program in National University Hospital of Singapore.
Kepada Dr. Dian, waktu dan tempat kami persilahkan.
Terima kasih. Thank you very much for the introduction. We shall begin this seminar and workshop today on diagnostic approach on pediatric upper airway. Thank you. So the first session, we would have a session about screening in pediatric upper airway. Especially, we tend to, this topic is for the general practitioner and also the general ENTs. The topics will be presented by Dr. Agus Surono, Ph.D., M.Sc, Sp.T.H.T.B.K.L, Subspecialist.B.E Constant. Maybe the curriculum vitae for Dr. Agus. If not, then maybe we started the presentation for Dr. Agus. The time and place is yours. Thank you.
Ya, terima kasih. Saya lanjutkan. So if you have any question or comments, so please feel free, and then do not ask to me, but ask the expert, especially Prof. Chung, because they has many solutions for whatever the problem in the pediatric upper airway. Thank you. I'm sorry, in bahasa Indonesia. Ya, slide berikutnya. Jadi nanti di akhir acara nanti ada beberapa, silakan ada beberapa sejawat baik yang offline maupun online punya kasus disampaikan saja, karena kita memang ingin memperbanyak kasus-kasus yang ada untuk diskusi. Ya, sebagai pengenalan untuk pediatric airway problem, kita harus mengetahui definisi dari masalah-masalah di jalan nafas baik atas maupun bawah, kemudian impact-nya pada pasien-pasien anak, dan harus berpikir bagaimana 20, 30, 40 ke depan, apakah dia masih survive atau tidak, bagaimana quality of life-nya. Kemudian kita harus mengenali beberapa penyebab-penyebab maupun tanda dari pasien yang mengalami masalah di upper airway. Dan pentingnya early detection dan intervensi pada kasus tersebut, dan kita nanti melihat beberapa kasus, ya, beberapa diagnosis pada pasien-pasien anak yang paling sering muncul dan metode diagnostik yang ada. Slide berikutnya. Nah, kalau kita lihat upper airway mulai dari hidung, faring sampai di bronki, kemudian masalahnya adalah adanya obstruksi baik parsial maupun total akibat kerusakan karena sakit maupun karena congenital defect. Nah, banyak kasus yang kita jumpai selalu dikambing hitamkan adalah laringomalacia. Di awal-awal kami mengembangkan pediatric airway ini, selalu yang kita temukan laringomalacia. Dengan kami banyak belajar bersama teman-teman di institusi lain, kita sering bergabung, ikut fellowship, ternyata laringomalacia bukan menjadi momok lagi. Artinya banyak diagnosis lain yang berperan di situ, dan keterlibatan pada center pusat dari Arab, ya, terutama pada yang perkembangan otak yang lambat, adanya sindromik maupun non sindromik itu yang muncul. Kesannya laringomalacia, tapi ternyata efek dari sentral. Dan kami menemukan kadang-kadang sudah dalam kondisi yang buruk, sudah dipicu atau nicu, kemudian sudah terpasang intubasi, maka masalah lain muncul akibat pemasangan intubasi yang lama. Memang pada anak dianjurkan bisa sampai 2 minggu, ya, dengan dewasa yang kalau sudah ada indikasi lama sebaiknya diterakostomi. Tapi pada anak kadang-kadang mereka mempertahankan 2 minggu. Bahkan ada yang sampai 1 bulan setelah diketahui kegagalan ekstubasi. Dan ini yang kadang-kadang saya tidak tahu apakah karena teman-teman yang lain kurang paham atau kitanya yang kurang proaktif menjelaskan bahwa ini ada sesuatu loh. Itu. Berikutnya lagi. Nah, beberapa penyebab yang muncul adalah adanya yang paling umum yang kita jumpai ya, adalah adanya pembesaran tonsila palatina, kemudian adenoid yang menimbulkan snoring, kemudian lanjut lagi mulai dari osa yang ringan sampai berat. Itu yang paling umum terjadi. Tapi kalau kita ke bawah, ada lagi beberapa variasinya. Itu adalah congenital abnormalities di jalan nafas. Kemudian tidak juga kita temukan banyak kasus karena ada pneumonia yang lama, dirawat yang lama, maka akan timbul beberapa inflamasi atau dampak dari alergi yang menyebabkan edema di daerah jalan nafas, baik yang upper maupun yang lower. Kemudian adanya trauma, sekarang banyak kecelakaan maupun tawuran, ya, sehingga menyebabkan luka di daerah airway, kemudian adanya benda asing. Nah, ini suatu ilustrasi gambaran kalau kita menemukan kasus laringomalacia, di mana adanya pemendekan antara epiglotis dengan arytenoid, kemudian ini adalah operasi. Ya, teorinya seperti ini, tapi pada prakteknya tidak semudah ini karena komplikasi yang ada itu sudah terlalu banyak. Nah, pentingnya kita awareness. Ini masalah apa atau ini? Ya, memang kendala kita adalah endoskopi yang masih mahal ya. Nah, beberapa contoh yang kongenital adalah tracheomalacia, ya, kemudian adanya laryngomalacia, ada vocal cord paralysis, apapun penyebabnya, dan stenosis subglotis. Ya. Kalau di pasien-pasien PICU, NICU, kadang-kadang sudah terjadi seperti ini karena penggunaan intubasi yang lama, kemudian pasien juga bergerak-gerak, dan sebagainya. Nah, kadang-kadang tracheomalacia ini juga bersamaan dengan laryngomalacia. Yang ingin saya sampaikan di sini adalah tidak hanya melihat laryngom maupun tracheomalacia, tapi di atas ada masalah tidak. Ini bagian yang murni karena tracheolaryngomalacia atau bagian sindromik. Bagaimana dengan pertumbuhan di otaknya? Nah, ini yang penting buat teman-teman mungkin di anak, ya, saya titip Dr. Amalia ini. Beliau ini juga sering bekerjasama dengan kita, sama-sama Airway, ya, sering diskusi bahwa kalau kita mengenal seperti ini kita harus melihat secara general, ya. Tidak hanya masalah airway-nya saja, ini masalah sentral atau bukan. Karena apapun operasi kita, kalau sentral itu bermasalah, terutama yang dikembangkan Dr. Zulka, yaitu Pediatric Dysphagia. Itu ternyata variasinya banyak banget ini. Ya, nanti kalau pengennya sama beliau ini, karena beliau sedang sibuk membuat buku. Karena beda ya, disfagia antara pada anak baru lahir, pada neonatus, sampai anak usia sampai 18 tahun itu banyak sekali variasinya. Lokusnya di mana lesinya juga bervariasi. Dan disfagia otomatis terjadinya retensi saliva, otomatis terjadi aspirasi, otomatis terjadi inflamasi di laring sampai ke bawah, pneumonia. Nah, yang kambing hitamkan adalah pneumonia, infeksi. Lupa bahwa masalah utamanya adalah gangguan pada sentral perkembangan yang lambat, yang tidak sempurna yang menyebabkan aspirasi berulang. Ya, ini sering kita jumpai. Ya. Kadang-kadang keterlibatan teman-teman di pediatrik neurologi juga di awal. Ya, karena pasien sudah terlanjur di PICU sekian lama, kemudian baru ke bangsal, baru kita lacak lagi. Nah, mestinya dari awal kita analisis. Karena saya dengar di teman-teman di PICU sudah ada USG, ya, kemudian ada alat-alat yang lain, mestinya deteksi dini itu penting. Tidak hanya kegawat daruratan pada jalan nafas, tapi juga masalahnya apa tuh. Dan yang kita kembangkan bersama-sama, tidak sekedar melihat airway-nya saja, tapi efek sentralnya ada tidak. Kalau ada, masalahnya di mana? Ini suatu non-sindromik atau sindromik. Jadi berkembang lagi. Dulu di awal kami hanya melihat ini, wabar airway, menemukan laryngomalacia senang banget. Bisa operasi senang. Setelah operasi kok dibangunkan nggak bisa. Kok tetap floppy terus epiglotisnya. Nah, pneumonia tidak tertangani dengan baik. Nah, sehingga kita berpikir jangan-jangan itu. Dan kambing hitam yang berikutnya adalah pneumonia akibat dari nosokomial. Udah kena karena pengaruh ventilasi yang lama, dia jadi pneumonia. Tapi kita lupa melihat dari awal. Makanya jangan kita memposisikan diri di saat kuratif, tapi awareness tadi loh. Dan mungkin beberapa teman nanti saya mohon untuk berani untuk melakukan, ya promosi webinar lah paling mudah. Tapi jangan yang berbayar, kalau syukur yang gratis. Nah, sponsornya biar dari rumah sakit. Karena kalau berbayar nanti masyarakat umum untuk sungkan ya. Ini kan punya dokter, saya nggak bisa untuk ikut. Tapi kalau umum sebagai bentuk pengabdian masyarakat itu penting sekali ya. Terutama dokter-dokter umum yang ada di ujung-ujung kita, pengenalan penting. Jangan melihat, oh nanti yang diobati bisa, tapi dampaknya itu loh. Ya kalau bisa sembuh sempurna, tapi kalau ada kecacatan. Nah itu. Kemudian ada beberapa tanda-tanda yang muncul pada masalah-masalah yang di airway problem ya. Adanya kesulitan bernafas, nafas pendek, adanya usaha bernafas yang berlebihan. Nah ini kadang-kadang kita diskusi dengan Dr. Amalia dari Respiro Anak, ini masanya di bawah atau di atas. Kadang kita home pimpah. Karena bingung yang mana dominannya. Kalau atas kita perbaiki, bawahnya masih bermasalah. Dan kalau penyakit terutama di rumah sakit mestinya masalahnya atas dan bawah. Ya. Oke, laring kita tangani, tapi pada faktanya kalau pneumonia lama juga terjadi masalah di laring. Dan pasien pasca ekstubasi yang lama, walaupun dia bisa survive, terbanyak adanya edema. Mulai dari epiglotis, aritinoid, laring, sampai daerah subglotis. Yang kita khawatirkan kalau itu menjadi hipertrofi atau hiperplasi, menyebabkan penyempitan tadi. Ya. Kemudian adanya mendengkur, ini kalau kita orientasinya pada obstruktif sleep apnea. Ya. Kemudian batuk yang lama, kemudian sering berdehem misalnya. Kalau batuk yang lama kita perhatikan ini karena alergi. Kadang-kadang kan kita seperti itu. Oh ini alergi aja ini kurang makan aja. Kita lupa pada anak-anak kemampuan menelannya bagus tidak. Karena kan nggak bisa komentar, ngomong aja belum tentu jelas masalahmu apa. Apalagi kadang-kadang orang tuanya yang kurang care. Maka dalam pediatrik dysfagia itu adalah caregiver itu penting sekali. Tapi masalahnya caregiver-nya itu bukan ibunya, tapi pembantu. Ya oke lah ibunya S1 sampai S3. Ini pembantu kan S.A.P.O. loh. Yang kadang lulusan SD, SMP, bagaimana dia suruh paham gitu loh. Ya. Makanya kita jangan orientasi aktif lah, kalau bisa preventif, promotif ya. Kita sampaikan ke mereka. Kemudian adanya tadi ini kesulitan menelan ya. Pada anak 3 tahun, 4 tahun kadang-kadang kita, oh ini hanya picky eater. Dia hanya milih-milih. Iya, Po. Kita pastikan dulu, benar tidak? Ya, mungkin nanti lain waktu kita akan membahas workshop tentang pediatrik dysfagia ya, pengenalan dini. Karena antara anak dengan dewasa itu beda variasinya. Kemudian adanya infeksi yang berulang, recurrent problem, pneumonia muncul lagi, difoto bersih, nanti datang lagi ini sampai bosan malah ini kok orang mari-mari kenapa ini? Kok nggak sembuh-sembuh kenapa ini? Ya, tuh. Kemudian, nah ini tumbuh kembang yang tidak bagus, berat badan yang tidak bisa tercapai sesuai dengan kartu menuju sehat. Kita harus care ini. Jangan, oh TBC ini, yakin TBC? Belum tentu. Ya, jadi harus holistik melihat ini. Clinical reasoning-nya kita harus jalan, jangan main tebakan. Ini terutama teman-teman yang di ujung tombak ini, ya agak care lah. Ya, paling enggak cari pahala sedikit untuk lebih care pada pasien-pasien yang tanda mungkin membutuhkan perhatian kita lebih. Ya. Kemudian kalau kita bandingkan nanti ada yang upper dan lower ya. Kalau di upper kita menemukan mulai dari hidung, adanya hidung yang tersumbat, kemudian snoring. Hidung tersumbat itu unik ya. Sebenarnya kalau paling mudah kita lihat dia nafasnya selalu pakai mulut, kemudian pertumbuhan gigi yang enggak bagus, kita lihat kok hidungnya, konkanya enggak edema ya. Tapi dia kesulitan paling gampang jangan-jangan di belakang ada masalah. Itu paling gampang. Dan kita nggak perlu lihat ronsen dulu, ini kayak belakang ada masalah nih. Karena konkanya bagus, dilihat depannya bagus, tapi dia merasa tersumbat. Nah, jangan-jangan hipertrofi adenoid. Ya. Kemudian adanya nafas pakai mulut ya, kemudian stridor, adanya retraksi, kita ingat Jackson apa namanya? Klasifikasi ya, mulai dari retraksi suprasternal, kemudian interkostal, kemudian keterlibatan effort dari diafragma yang keangkat saat kita bernafas. Kemudian kita mempertimbangkan penyakit yang menyertainya. Dan nanti masalah manajemen oleh Prof. Chung. Ini yang lower ya, walaupun bukan di THT, tapi kita harus memahami juga masalah-masalah yang penting. Yang penting misalnya ada asma, ya, kemudian ada batuk yang berulang, nafas yang pendek, kemudian adanya infeksi-infeksi yang menyertainya baik akut maupun kronik, ya, kemudian adanya riwayat alergi dan penyakit-penyakit yang lain. Oke, kita menuju ke beberapa contoh pada upper airway. Yang pertama adalah adanya benda asing, ya. Apapun itu pun benda asing, baik itu hanya di trakea maupun sampai ke daerah bronkus. Ya. Untuk yang besar mungkin hanya sampai bronkus primer. Tapi yang pecahan kacang misalnya itu bisa sampai ke bronkus sekunder. Kadang-kadang pemeriksaan foto ronsen ini enggak apa-apa kok. Tapi tanda-tandanya sudah pasien sering batuk. Karena anak-anak kan tidak tahu saya habis makan apa, saya habis tersedak apa. Kadang-kadang mereka tidak bisa mendeskripsikan dengan jelas. Nah, pada pemeriksaan yang gold standarnya adalah menggunakan CT scan. Dan mereka bisa menggunakan 3D ya untuk mengetahui permasalahan yang ada, apakah ada di bronkus, apakah ada di bronkus sekunder, dan sebagainya. Karena kalau menunggu munculnya manifestasi di daerah ronsen ini, kemudian tampak, kemudian baru muncul ada tanda-tanda auskultasi yang berbeda, berarti menunjukkan keparahan. Karena ini merupakan sesuatu yang harus situ atau emergensi kita ketahui ada tidak keterlibatan benda asing pada masalah airway tadi. Yang kedua, laryngomalacia, ya, kita lihat ada 3 tipe, mulai dari normal sampai 3 yang paling berat. Faktanya, gambar ini tidak menunjukkan sesuatu yang sama di beberapa pasien, banyak variasi. Kadang-kadang tipenya kombinasi antara tipe 2 dan 3, seperti ini, kadang-kadang kolaps ya. Seperti ini juga, ini pasti masuk ke NICU atau NICU, karena tertutup. Ya. Nah ini intubasi bagi teman-teman dari anestesi maupun dari PICU-NICU juga akan kesulitan. Dan kalau diusahakan 3-4 kali melakukan intubasi, ya sudah kita harapannya ada trauma di laring. I remember with your suggestion, Prof. Chung, dan please take care with laring. Do not manipulate the laring several times. Itu saya ingat-ingat sekali itu. Dan berkali-kali Dr. Ezi juga menyampaikan, nggak bisa perhatikan apa. Jangan dicoba-coba. Mulai dari residen yang pertama, residen yang tengah, residen yang berikutnya yang tinggi, kemudian DPJP yang muda, DPJP yang senior, nggak bisa panggil anestesi. Nah, itu THT siap-siap nih ya, Dr. Ezi, Dr. Suka, tracheostomi. Salahnya kanulnya tidak tersedia. Nanti yang repot. Yang disalahkan THT tidak mau tracheostomi. Padahal alatnya nggak ada. Kenapa nggak ada? Rumah sakit belum membayar sama vendor. Masa sepele gitu kadang-kadang itu loh. Kita punya kontak person dengan mereka, mereka punya, tapi rumah sakit nggak bisa beli. Nah, akhirnya kita kadang-kadang nyumbang. Ya, nah, masalahnya sama semua kan? Iya, itu kita korban semua. Different with in NTU, it's every candle available there. Whatever the numbers, but sometimes we have difficulties to provide that tracheostomy tubes, ya, yeah. Especially for the apa yang untuk bicara itu, ya, yeah. Yang like speaking valve itu, something we have a difficulty to provide through the hospital, although the vendor provided. Itu. Jadi masih kita sama ya, Indonesia masih sedih ini. Tapi sudah merdeka berapa tahun, Bu? 14 tahun. Udah lupa. Ya, ini ada beberapa contoh laryngomalacia dengan banyak variasinya. Kita ingat bahwa sebagian besar masih bisa revolve pada usia 2-3 tahun kemudian. Tapi harus kita pastikan adalah tanda-tanda masalah munculnya menetap tidak. Tumbuh kembangnya terganggu, recurrent pneumonia, ya jangan tunggu resolve dong, harus segera diantisipasi di awal. Jadi kadang-kadang operasi itu kita kerjakan pada tipe 1, tipe 2, tidak menunggu tipe 3 dulu. Ya, oke, baik, tapi pneumonia berulang, tumbuh kembangnya kurang, makanya terganggu. Ya kenapa kita nunggu yang paling berat dulu? Dari awal harus kita antisipasi. Nanti kalau gimana dok caranya operasi ini? Nanti ke RSCM Velo. Ya. 1 bulan boleh ya Dr. Ezi? Boleh itu. Oh, 3 bulan. Enggak, velo yang untuk tahu aja. Pelatihan 3 bulan, nanti masalah bayar dan sebagainya Dr. Ezi lah yang lebih tahu. Tapi jangan khawatir, selama di Jakarta akan di take care sama Dr. Ezi. Masalah makan minum jangan khawatir. Ya. Oke. Nah, kemudian ini yang paling sering juga adalah tentang epiglottitis ya, peradangan di epiglottis, kebanyakan karena virus. Ini merupakan emergensi karena pada saat edema yang berat menyebabkan obstruksi pada daerah laring. Kemudian crop ya, adanya inflamasi mulai dari laring dan khasnya itu batuknya seperti anjing menggonggong ya pada anak-anak. Ya, itu ketimbang crop ya. Kemudian ada vocal cord dysfunction, apapun variasinya bisa unilateral, bisa bilateral. Kemudian ini tadi ya subglottic stenosis terbanyak pada kasus karena trauma dan intubasi yang lama. Nah, ini yang merupakan paling umum terjadi ya, apapun penyebabnya, bisa asma, bisa COPD kalau pada anak-anak yang lebih dewasa atau kelainan pada jantung, yaitu adanya reactive airway disease ya. Karena kita nggak tahu ini yang jadi momok teman-teman anestesi selalu bilang ini ada hyperreactive airway sehingga mereka takut untuk membius. Atau menakut-nakuti kita nanti kalau DOT bagaimana, death on the table seluruh rantai itu. Ya. Mereka takut, kita juga takut akhirnya. Karena apa? Konsekuensi dari hospital law tadi. Kemudian screening, yang penting adalah kita harus memperhatikan pemeriksaan fisik ya. Kemudian mengenali tanda-tanda maupun gejala-gejala yang muncul. Kemudian penunjang, ada X-ray, kalau bisa sampai CT scan ya. Tapi nggak perlu MRI, cukup CT scan bisa. Kemudian, nah ini kalau bisa disediakanlah fleksibel endoskopi baik untuk yang neonatus atau yang pediatrik. Salah satu boleh, paling aman yang kecil aja. Jadi bisa dipakai untuk orang dewasa, bisa dipakai untuk kecil. Dan ini kita juga ada 3 vendor, nanti silakan tawar-menawar di sana. Syukur ada yang menjual bekas, biasanya setengah harga. Ya. Jadi sudah saya tawar, yang dicicil bisa ada. Nanti kalau di THT ada koperasi, silakan ikut koperasi. Tapi nggak tahu lunasnya kapan ya. Kemudian mengevaluasi pernafasannya, kemudian during sleep. Nah ini kita juga nanti akan ada beberapa workshop tentang sleep disorder ya. Kemudian riwayat penyakit atau pengobatan sebelumnya. Kemudian beberapa tes yang kita perlukan lain adalah adanya bronkoskopi, laryngoskopi, sleep studies. Sleep studies itu agak unik dan kompleks ya, tidak sekedar melihat mereka mendengkur saat henti nafas, kita melihat video pasien saat dia tidur, tidak hanya sekedar polisomnografi, kita juga mengembangkan adanya sleep endoscopy, yang awake maupun yang DISE, drug induced sleep endoscopy. Ya. Nanti kita panggil Dr. Zulka untuk menerangkan bagaimana tentang studies ya. Kemudian ada tes dari fungsi paru, kemudian beberapa pemeriksaan laboratorium untuk menentukan apakah ini murni genetic defect dan metabolic disorder. Dan yang penting adalah tim. Jangan iki punyaku, ini pasienmu, tapi kita tim bersama-sama. Dan alhamdulillah beberapa center sudah terjaga antara THT dengan pediatrik, kemudian dengan rehabilitasi medik ya, seperti itu sudah bisa. Nah, saya kebetulan basicnya adalah genetik ya. Jadi genetik itu jangan kaitkan selalu berhubungan dengan yang diturunkan oleh orang tuanya. Karena genetik itu ada 2, ada yang inherited Mendelian pattern, ada yang non-inherited. Sama-sama kelainannya pada gen, tapi ada yang diturunkan, ada yang tidak diturunkan, atau istilahnya non-Mendelian. Jadi kalau non-Mendelian pattern artinya gennya bisa rusaknya sama tapi sifatnya sporadik. Nah, komplikasi yang sering muncul adalah adanya pertumbuhan, kemudian kognitif, resiko infeksi yang berulang pada pernafasan, kemudian kualitas hidup. Nah, ini strateginya bagaimana? Saya lebih senang pada awareness, ya, keterlibatan kita. Jangan dibebankan pada sejawat spesialis yang lain. Kita juga terlibat di situ. Karena THT itu kan juga berhubungan dengan airway terutama yang upper. Kemudian perlu pemeriksaan yang berkelanjutan ya bersama-sama dengan sejawat yang lain. Oke, ini yang terakhir mungkin adalah satu, tentang care providers ya. Kemudian kita perlu guideline untuk screening sama bagaimana untuk merefer pasien dan kolaboratif. Saya lebih senang kata kolaboratif ini ya, karena ini merupakan sesuatu yang mahal di kita. Diajak diskusi itu agak sulit, egonya lebih dominan. Insya Allah kalau kita bisa membiasakan lebih bagus. Saya melihat di NTU itu kolaboratifnya sangat luar biasa. Mereka gerubuk di situ bersama-sama. Dan kesalahan atau kelemahan kita adalah saat sejawat lain itu menulis lengkap, kita tidak membaca, langsung visit ke pasien. Tolong itu jangan dibiasakan seperti itu. Kita baca dulu expert dari mereka itu apa. Mereka ngomong apa. Kita periksa ke pasien. Jadi ada kelanjutan. Ini yang kita agak pelit karena waktunya terbatas, pasiennya banyak. Kita pelit apa yang disampaikan teman-teman di anak, misalnya anestesi bilang apa, baru kita lihat pasien. Jadi jangan lihat dulu baru, oh, aku saya habis edukasi tapi salah karena dari teman jawab lain memberikan edukasi yang berbeda. Itu yang paling sering ya. Ya, ini referensi saya. Terima kasih. Mohon nanti untuk aktif untuk diskusi karena waktu kita sampai 1 jam nanti dan akan dijawab oleh expertnya, tapi bukan saya. Terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Terima kasih Dr. Agus atas presentasinya. Jadi sebenarnya memang tujuan kita menyelenggarakan seminar dengan harapan supaya Pediatric Upper Airway ini yang tadi nggak terdengar ya. Terima kasih Dr. Agus untuk presentasinya. Nah, jadi memang kita menyelenggarakan seminar ini dengan harapan supaya Pediatric Upper Airway Problem ini menjadi lebih dikenal, terutama oleh nakes-nakes terkait ya, baik itu perawat, dokter umum, dokter THT, maupun dokter anak. Sehingga harapannya screening kelainan-kelainan yang bisa diatasi sejak awal itu menjadi lebih baik dan bisa menghindari keterlambatan tata laksana yang otomatis nanti prognosisnya menjadi akan lebih buruk. But, let's continue to the next session by Professor Dr. Wei Chung Su. Could you show me the CV, please? Okay. Prof. Wei Chung Su, MD, Ph.D. is a division chief and professor of the pediatric otolaryngology in the National Taiwan University Hospital. And the Bachelor of Medicine is finished in Medical School of National Taiwan University. The ENT resident training is also done in NTUH. And the doctoral degree is by Institute of Occupational Medicine and Industrial Hygiene, College of Public Health, National Taiwan University. Okay, to Professor Wei Chung Su, time and place is yours.
Okay, good morning, everyone. Hi, my friends from Indonesia. My sound is clear and the video is clear online. Thank you very much for the kind invitation from Professor Agus and Dr. Dian. This is my first time going to this hospital. Previously, I only had sightseeing around Yogyakarta. So today I'm going to share with you the management of the pediatric upper airway. And this is my personal CV that Dr. Dian has been introduced. But I just become the director of our sleep center in National Taiwan University since this August. So this is also the topic yesterday I shared with friends in Dr. Triple Hospital that the airway problem, including the sleep problem, is the same. And we are the specialist of the pediatric airway. So this is my hospital. Okay, this is better. So our children's hospital was built since 2008. I can very clearly remember because that was the year of my daughter born. And in 2017, Dr. Agus visited us. This is our department in the operation room. And also in the just before the pandemic, my family visit Jakarta with Dr. Dian and Professor Agus. Suppose Dr. Dian will visit us during the 2019, but unfortunately, in the end of the year, the outbreak of the COVID-19, so still not had the chance to visit us until now. Hopefully in the future, very soon. And nowadays, both of my kids are growing up and they have become the high school students. And also, but during that period, I also joined your online meetings with some presentations in 2021. Yeah, that's the, I don't know whether this restaurant is still here or not yet. Okay. Okay. Also, I just visited a lot of Indonesian friends during the international meetings and the airway courses. This is in the Seoul 2023. And next year, we will have the Asia Pacific Pediatric Airway course and the workshop in Indonesia. Okay. Okay, considering about the upper airway, it including the nose, sinus, adenotonsillar, oropharynx, larynx, and the trachea bronchus. Just as Professor Agus has been demonstrated that the conditions causing the upper airway obstruction involve multi-level obstructions. So most of the cases in newborn or small baby is congenital in 85%, but sometimes when you do some intervention, just like the intubation or any kind of surgical intervention, they will induce acquired larynx or airway problems. So according to some of the professional ENT, pediatric ENT airway surgeons, they say that most of the kids or most of the patient has only one chance, which means that the first one intervention very much important for the airway in the following. The first principle is that do no harm. If you cannot make the airway better, please don't do anything to the airway because you have to respect the airway mucosa, airway physiology, and also the airway anatomy. So always, before doing any surgical intervention, you have to do the comprehensive evaluation for the whole airway. Because it is very common that not only one lesion in the airway, many of the cases has the concomitant anomaly up to 50%. So always check up the whole airway from nose to the trachea and the bronchus. What we have, the instrument is rigid and the flexible endoscope. We are going to practice some of the flexible endoscope this afternoon. And the airway endoscope absolutely is necessary technique for all the pediatric ENT doctors, but not only pediatric ENT, also for the primary care, for the adult ENT is also very important. If you can use the flexible endoscope very skillfully, then you can have much more information inside the airway for the whole local examination of your patients. So it's very important, and you have to do the evaluation comprehensively. And also nowadays, because of the improvement of the surgical technology and the instrument, we can not only do the diagnosis, but also we can do the treatment by endoscope, either flexible or rigid endoscope. So it's an initial procedure for the pediatric airway management, and also either after open reconstruction surgery, it can be the adjuvant or revise or modify, even sometimes the rescue procedure for your airway surgery after the open airway surgery. So this is what I'm going to do now. under the assistance of our anesthesia for the stressful endoscopy. As you can see, in the very beginning, the anesthesiologist will always pre-oxygenations to keep the situation up to almost 100% if possible. Then you have plenty of time to do your procedure. And also, they just keep around the oxygen given, just around the upper areas. Just keep it fully of the oxygenation during your examinations. So it's very important to operate with your anesthesiologist, and you must have a very good first assistant, including your nurses and also your residents. Everybody should understand what you are doing and what is the next step is and what you are planning for this operation. So before doing any endoscope, should have everything in your mind, what kind of instrument you have, what the procedure you try to do, what the condition of your patient maybe have, then you can have immediate response during your decision making in your procedure. And of course, in some cases, if the airway is not so stable for children, you can through the laryngeal mask airway to do the endoscope procedures. And this is the rigid endoscope, what we call is micro laryngeal bronchoscopy. Then you have many monitors on right side and also left side, because not only you have to see the inside endoscope image very clearly, but also your assistant must know that where are you and what are you going to do, including the nurse and the anesthesiologist and your first assistants. So this is the procedure also before I'm doing the rigid endoscope. Our anesthesiologists use the ambu to keep some anesthesiologic gases and also the oxygen, pre-oxygenation to keep the patient as full saturations for your intervention. Then immediately you should wait the position of your patients with a little bit hyperextensions, neck extended, then you can reach to your airway very clearly, directly. But I use this one is to homeschool with a wider view during the endoscope. And then have well prepared on your systems. Then everybody can see where you are and what are you doing. Then they can respond. There are some emergency conditions. So always keep in mind that you must let everybody in the operation room understand where you are and what are you going to do. So the requirement for a very successful pediatric airway endoscopy, the first one should be skill. You have to practice. The second one, you have a very good instrument, very complete, from very small premature baby to adolescent, less than 18 years old. That's all that you must have. And you have your systemic evaluation procedures in your mind. You need to do everything the same, step by steps, and with the very good judgment to see how about the next step, what kind of surgery you can offer, and what's the next step for the baby. So this is all the different sizes from a very small laryngoscope, Parsons C-shaped laryngoscope, and also the rigid Costos bronchoscope with the ventilation working channel. And here you can cap to the head camera to connection to your videos. And here is the anesthesia cannulations. And different lengths, different size, different diameter, all the bronchoscope everyone you must have. And you can pick up under the list what kind of baby, what's the age, and what's the body weight. You can choose what size of the proper instrument that you want to do it. So the team approach is very important. You will not be able to do everything by yourself. Your nurse should be prepared everything for you. Once you face some problem, you need a new instrument. Your nurse should be able to read your mind. Before you speak out, then she has already handed the instrument to you. That's the team approach. It's a teamwork. It's a team sports. Then you will buy some time during your acute and emergent management. And the nursing in the ICU care is very important. So our pediatricians is very much important because after the surgery, we did a very good intensive care. And of course, the understanding of the family is all very important. You have to do the shared decision making with your family. So it will be never this condition that it seems that the surgeon always push the children into the operating room, but the pediatricians and the families on the other side. So we are so alone in the very beginning. But actually nowadays, if you can understand each other, what kind of procedure you can do and what's the level you can help the children, then we can have a very good pediatric airway team to treat the baby very well. So the airway surgery, including the endoscope procedure, and of course, we are head and neck surgeon, so we can do the open airway surgery. And the tracheostomy is most simple and the most easy one. But before doing the tracheostomy, you still need to considering is there anything you can do to avoid the tracheostomy in children, because you must know that after the tracheostomy in a child, it will keep a long time with the baby, keep a long time with the child. Not only the airway problem, it will involve some speech problem and also some swallowing problem for these children. And sometimes in children, just do nothing and wait and see. After they growing up, step by step, something will become better and better. Okay, so let's go directly to the setting the age of the airway surgeries. Before the 1970s, the endoscope surgery was the mainstay for airway surgery, including the buccination, dilatation, and any kind of endoscope procedures. However, after 17 and before 2000s, lots of different kind of airway surgery was development, either from US or from Europe or something from the Asia. Everybody's saying that it should be an open airway surgery. But after 21st century, there is a research of the endoscope procedure because we have more and more better design instrument, including the illumination of the endoscope, and we have more and more laser, electrocauterization, microdebrider, coagulators, and any kind of medical new instrument make our endoscope surgery can do much more and more procedures. So in global view, summary, that's endoscope procedure, you can do the dilatation, you can do the splitting, and you can do the grafting, you can do the stenting, and the local injections such as the steroid injection or topical spraying, and you can do endoscope suturing for the laryngeal cleft, and also any kind of microscope surgery. And I do hope that in the future, robotic surgery can be involved into the endoscope procedure of the pediatric airway. And open airway surgery, including the resection, expansion, and the sliding surgery. I will talk about it later. So the most important concept is that you must look into your laryngeal trachea skeleton and make up your mind that you try to do endoscopy or open airway surgery for the laryngeal trachea stenosis. If your framework is intact, which means that the cartilage is intact, there is no damage or no extra lumen trauma of your airway skeleton, then you might be able to success by endoscope procedure to doing the airway dilatation or augmentations. But if it's a very severe traumatic injury to your airway, there is normal, well structured framework, absence of lung cartilage, and weak or degraded framework, then you should do the open airway surgery directly. So the second concept is from the open airway surgery, there are 3 different types of open airway surgery. One is augmentation by any kind of grafting, like the costal cartilage graft or auricular cartilage graft or any artificial graft. The second one is resection. You just remove the disease part and do the end-to-end anastomosis to your airway. The third one is a little bit more technical challenge, is a sliding tracheoplasty. It's originated from doing the congenital tracheal stenosis, but also we can do some cervical sliding in urothelial stenosis in young adults. So this is the laryngeal tracheal reconstruction with anterior
grafting
costal
is used
grafting.
to manage mild to moderate subglottic stenosis.
So
Subglottic
can we
stenosis is a narrowing of the airway
make the sound a
at the
little
level
louder?
of the cricoid cartilage. A vertical anterior
Well,
split
I
is
think
made
on the
through the
website it's
cricoid,
okay, but
2
here they
tracheal
can
rings, and part of the thyroid cartilage. We do not split through the vocal cords.
But here
Is
I
that
just
the-
close the sound
A
because there
piece
will
of
be
rib graft is harvested.
But in briefly, that's you take the
We
rib
create a boat
as
shape
your
while
grafting
preserving
and
the
make it as a
perichondrium.
keystone shape to do the anterior grafting.
This is
So
then placed into
just
the defect
told my
and
resident and
sewn
student that
using
this is
interrupted
just the
sutures.
Lego surgery. You make a very fit
Lastly, we check to
grafting
ensure there
in
is
your
no air leak.
stenosis part, then fit into the stenosis part, make your airway a little bit widening. This is the cartoon made by Cincinnati Children's Hospital. Okay, and another one is the resection. This is tracheal resection. It's indicated for the more severe, like the severe grade 3 or the grade 4, subglottic stenosis. So the basic idea is that you remove the disease part, which including the anterior 2/3 of the cricoid cartilage, and also the first tracheal ring or even extend to the second or third tracheal ring if the stenosis part is there. As you can see in this cartoon, the first tracheal ring is also stenosis, sorry, the first one and second one. So after you remove the part, you have to do some management of the posterior part of the some cartilage. The soft tissue of the stenosis and then you remove upper portion of your grafting to make an end-to-end anastomosis. And first you do the stay suture, and then continuously repeat anastomosis. Yes, to make the airway wide open. And the sliding is another idea that because it's a congenital tracheal stenosis, so you try to slide your stenosis part of the trachea airway to make your airway a little bit shortened, but you can opening your airway anterior and posteriorly. It's a little bit simple when you look into the cartoon, but actually it's not an easy surgery. Yeah. Usually, if the diagnosis part is intrathoracic, you should do under the cardiopulmonary bypass. So you need the help of your cardiovascular surgeon to do the bypass, and then you can have plenty time to make the continuous suture in your airway. That is the sliding tracheoplasty. Okay. So another concept is that before you doing any surgery, you must comprehensively do the preoperative evaluation and the optimization of any kind of procedure you want to do it, especially in the revision surgery, because you never know that the patient has been received some kind of surgery outside your hospital. So the pre-op evaluation is really very important, and you need your team to do the triple scope, including the expo and the rigid laryngoscope is the MLB, and also the esophagoscope to see is there any reflux or any eosinophilic esophagitis in your patients. So the recent advancement in our airway surgery, including the improvement of the instrument and also the video system. Nowadays, it's not only high resolution image. We have the 4K images, even much better than your naked eyes. And another issue is that the anesthesia is very much important. Not only we have the inhalation, we have the jet ventilation, and we have the high flow ventilation, which can make your surgery much more better, and you have a longer time to do your surgery in a very delicate status. So you have to training yourself, and you have to training your team to make a better approach. Endoscope is not only the diagnosis, it also can be the therapeutic purpose. So that's the reason why nowadays we can avoid the tracheostomy in a very small children as much as possible. So the therapeutic bronchoscopy, including many cases. In the very beginning, the traditional foreign body remove, laser bronchoscope, endoscope electrocauterization, stenting, dilatation, and also for the lower airway, you can do the selective bronchial lavage with the intermittent jet ventilations. And you need to have many kind of X-ray instrument as your adjuvant therapy. Laser, microdebrider, dilator, T-tube, stenting, and the foreign body steps, etc. Laryngomalacia is the most simple ones everybody knows, including the inspiration collapse of and prominent cartilage. So in severe cases with the feeding difficulty or failure to thrive, episodic cyanosis, recurrent pneumonia, or chest wall deformity called pulmonary, you can do the supraglottoplasty to rescue this child, to avoid intubation, avoid tracheostomy. Laser supraglottoplasty, including the AE4 epiglottoplasty and the Sp.T.H.T.B.K.L. Epiglotoplasty, just as a kind of circumcision of the larynx. You just remove the supraglottic soft tissues, which will cover and obstruct your airway. You can do it by microscissors, microdebrider coablator, or you can do by any kind of laser. More delicate will be much more better. And the second part of supraglottoplasty, just like the barbecue of the epiglottis, as you can see with the laser heating, you can see the epiglottis open gradually, step by step, just you doing the barbecue in your skin. So the supraglottoplasty, including Sp.T.H.T.B.K.L, division of the AE4, and the trimming of the cuneiform cartilage. And the another one procedure that you can do is that in children with bilateral vocal palsy, sometimes the pediatrician and also the parents is very much hesitate to do the tracheostomy because they know that once you do the tracheostomy in this newborn, they will keep a lifelong time with the tracheostomy. up to 6 years old. So in Cincinnati, we try to develop some kind of endoscope procedures for some percentage of the lucky vocal palsies. As you can see in this flexible and the rigid scope, it's not totally paralyzed of the vocal fold. The lateral vocal fold is still in the paramedian positions, which means that there are some space for the airway to pass during the child respirations. What we can do is that we can do the anterior division and also posterior division of cricoid cartilage. You just split here and split outside. And next step, doing the balloon dilatations. So after splitting your cricoid, you have already released the tension of the cricoid cartilage. Then use a little bit oversized balloon to open the airway. Either 1 or 2 millimeters will make the baby much more better to easy have the breathing. And then keep it in the intensive care unit with oversized intubations for about 10 to 14 days, and then remove it to see if the patient can tolerate or the respiration is better. At the level of the cricoid cartilage, because you made the incision the upper and the lower part, there is no graft, only splitting of the cricoid cartilage, only splitting, yeah. So in details, the endoscope anterior posterior cricoid split, including the suspension in a medium-sized laryngoscope, Lindholm is the best one. And the under spontaneous ventilation, and you need the laryngeal expander for the infants, and doing the anterior posterior splitting of your cricoid cartilage under endoscopic guide or under microscope, and then repeat once or twice balloon dilatation, and then intubate with larger endotracheal tube, which means in a premature newborn, you might need to do it 4.0 or 4.5 endotracheal tube, and then intubate, stay in the intensive care unit for 10 to 12 days, then remove. And also, if just only splitting is not enough, you can try to put a posterior grafting in the posterior grafting part under endoscope procedures. It looks very fancy, but it's really not easy because you are working in a very small space, in a very small child. So you need to very delicate to put a real regular size of the posterior grafting into the posterior grafting part. That's the operation event by the Professor English from the Seattle Children's Hospital. And also nowadays for the vocal palsy, it's more charming is that selective laryngeal reinnervation is very successful in adult patients, especially after some iatrogenic trauma like the thyroid surgery. But nowadays we are trying to do some cases in small children, but it's not easy. You must do it under microscope and highly selective your NSA, hypoglossal nerve, or any vagus nerve branch to do the reinnervations. And for the subglottic stenosis, of course, as everybody knows, that is the male Cotton grading system. Professor Cotton has already retired, and the Professor Mile this year, he will also retire. And the grade 2, usually we can do endoscope procedures. And the early grade 3, maybe you can successful in the endoscope dilatations. But if up to severe grade 3 or grade 4, totally obstruction of the subglottic stenosis, you might thinking about the open surgeries. So the endoscope dilatations, you can use any kind of dilators if you don't have the balloon. to use in your hands. But be careful that use any kind of juxon esophageal bulge or pentabolic bulge, you will make the airway trauma much more. So you have to be very careful during the dilatation. And the balloon dilatation, if you don't have the airway balloon, you can try to use the vascular balloon, but not so effective immediately as you expected, but just repeat 1 or 2 times, then you can get a better airway after your dilatations. So this is just the demonstration under endoscope guide balloon dilatations in the subglottic grade 3 stenosis of these children. As you can see, after initial dilatation, the air is much more better and the respiration status is improved. Then you can try the second time immediately. Or sometimes if the scarring is too much, too stiffness, then you can use your scalpel to make some division, or you can inject some steroid locally to release the scarring formation. And this is the same demonstration of what I'm doing in the operation room. And as you can see, during the balloon dilatation, the airway is totally obstructed by you. So your anesthesiologist must have a very strong heart, because you can see the situation will be decreasing gradually and gradually. So it depends on how low the situation you can tolerate and that your anesthesiologist can tolerate. So usually we will suggest at least you need to do the balloon minutes in place to do the inflammation, to do the inflations, and twice in one operations. Then after regularly follow up, you can see how is the successful rate and how does balloon dilatation work for these patients. And this, I think, is just the demonstration of, just 1 month later after the dilatation, as you can see, it's already wide open, but here still has some scar. So you can use laser or use your scalpel to division the scar. Okay. So here I use the scissors to cut the posterior scars. It's a micro scissors. Yeah. Okay, so the guideline for the balloon dilatation, here is the formula. You should take the proper outer diameter of an age-appropriate endotracheal tube to sizing what the current status of the children. Then add on 1 millimeter for your larynx dilatation, add on 2 millimeter for the trachea dilatations. Example, in a 4-year-old child with the 4.0 endotracheal tube, the outer diameter is 6.8. Then you can use the 8 millimeter for your 8 millimeter balloon to your larynx dilatation and 9 millimeter for the trachea dilatation. But there are still so many controversial parts, and we don't know what is the principle, including what kind of size is better and how much the pressure is appropriate, because you have to make the judgment in between the complication and your successful dilatation, and how long you need to leave it inflated, and when to repeat, every week, every 2 weeks, every 1 month, and is there any additional procedure you need to do, such as the steroid injection or scar division or laser divisions. And the most important is that when to give up endoscope procedure and jump into the open airway restrictions. So this is the new balloon designed by my teacher, that's Professor Mike Rutter, because the balloon dilatation for airway still has the sliding problems, that because if here is the more stiffness, during the inflation of balloon, they were sliding. So this is a very smart design that anterior, posteriorly, then fix the position, then inflate the middle part, will be much more better, much more effective in your balloon dilatations. Microdebrider is a very quick and a very easy instrument that you can use for doing the valvular cyst, tongue-based cyst, or sacral cyst. As this video demonstrated, you just set up your endoscope and then just do the microdebrider, then you can finish the surgery just in 1 or 2 minutes very quickly. Then you can see your larynx very clearly. So it's a very good instrument. And also you can apply your laryngeal papilloma. Then you can set up your airway in a very quick and a very short time. But in this case, I didn't have the tracheostomy in these patients. We just open the airway by microdebrider. And also, you can treat the suprastoma granulations just before decannulations. I think this microdebrider is common for our endoscope sinus surgery, right? So you can also use the larynx device to do it. Yeah. So it's a microdebrider assists endoscope airway surgery, including any location of the laryngeal cyst, sacrotic cyst, or papilloma, or hemangioma, either the laryngeal web. You can try to do it. The advantage is that it's a very short surgical time, and you can early extubations and early remove the NG tube to make the baby can early oral feedings. It's very safe and effectively. And laser, you have different kind of laser, including a CO2, ND-YAG or KTP or diode laser, any kind of laser, you can use it. From the nose, you can do the laser turbinoplasty. Valvular cyst, you can do the laser extubation. Papilloma, you can do the laser engine, and the congenital fistula, you can do the cauterizations. And this is the same suprastoma granulation, you can use the laser, but it will take a longer time of your procedures. The benefit is only that there will be no bleeding during the procedure, but you should keep in mind that during the laser procedure, you should ask your anesthesiologist to lower down the oxygenation, even to the room air, to avoid the airway fire. And also for the distal part papilloma, such as the trachea invasion of the papilloma, you can use the KP laser to ablation the lower airway papilloma under bronchoscopic guide laser procedures. And also for the recurrent T fistula, we can use the laser ablation plus the biocauterization with some tissue fibrin glue to seal the small fistula. So the principle is that you do the laser to cauterize and to remove the epithelium to make a roll surface in the fistula. Then use the tissue fibrin glue as a glue to adhesion the fistula. So the treatment for recurrent T fistula, always for the pediatric surgeons, they don't want to reopen the chest because the first one is that it's very difficult to find the exact position of the fistula. The second one is that there is more higher risk. After the surgery, the patient should send to the ICU care. So what's the basic principle for endoscope procedure management is the deep epithelialization of the fistula and then tissue glue for the tissue adhesion. Combination to procedure together, then you can have some certain percentage of the successful rate in the healing of the recurrent TE fistula. And also for the congenital P-form sinus fistula, the fourth brachial cleft fistula, you can also use this procedure. This is what we publish in the International Journal of Pediatric Otolaryngology. And the foreign body removed with different forceps, you can remove everything, such as this is just the is a teeth during the dental procedures. So we just remove the foreign body in the right main bronchus under direct vision of the forceps. Yep. And the fetal surgery. Intrapartum procedures. During the umbilical cord still there, you can do some airway rescue in these babies. And you need a very huge operation room settings. And this is our first case of the oral teratomas. Connection to the tongue and also the palates. And the second case is the huge lymphangioma in the neck. And also for the lower airway disease, you can use the selective bronchial lavage with intermittent jet ventilations under the general anesthesia with rigid bronchoscope and combined with the high frequency jet ventilation. In this premature baby, less than 700 grams, only 17 days, he has the congenital collapse of the right side of the lung parenchyma. So you just doing once for the jet ventilation and lavage and the jet ventilation again, then you can open the lung immediately. And in some cases of the congenital heart disease, after the open heart surgery, the lung condition is not good. You can repeat and repeat for 3 or 4 times to open collapsed lung, to open the atelectic lung. And also in the other cases, is the left side collapse. You can do the endoscope procedure, reventilation the left side of the lung to avoid long-term ventilation support and to avoid the future tracheostomy for this baby. So the last concept for that is that the surgery is not only for airway. You should consider about the voice, language, swallowing, and some reflux disease. Not only the anatomy, you should consider about the physiology. As you know, in the newborn baby, in the very beginning, they try to survive. So the respiration is most important. Thereafter, if you receive the tracheostomy, then family and the doctor try very hard to remove the tracheostomy as soon as possible. Until the school age, they try to participate the school activity like the sports, then you should try to training their pulmonary functions. But after they growing up, the voice become the major problem because they try to have a good job. They try to find a better partner to marriage. Even in some female patients, they need to get pregnancy. So the last idea I want to transfer to you is the airway surgery is not only concerned about the airway. We should considering about the swallowing, voice, and also the nighttime sleep apnea problems. So from the anatomy to the physiology, from day to night, from childhood to adulthood, that's because of their quality of life. They will come back to you again and again. So nowadays, the successful of the pediatric airway reconstruction, not only the declination, not only the symptom-free airway, but also including a better swallowing outcome and the better voice outcome. Such as in these cases, in the very beginning is a total grade 4 stenosis in the subglottics. And you can see in the CT scan is the same, is total obstruction of the subglottics airway. And of course, in the very beginning, because the airway is obstructed, there is no swallowing problems. And we do the cryotrachea resection for these patients. And you can see the airway is quite patterned after the surgery. So which means that the airway reconstruction is very much successful. However, after operation 4 years, as you can see in the lower part of the lung, they are repeated aspiration again and again, which means that this boy has some problem of the swallowing. So we do the video fluoroscope for these children, and also the fees for these children. And you can see there are some silent aspiration into the trachea. And also in the fees with the blue dye test. You can see there are so much laryngeal penetrations, and also in the trachea, there are some silent trachea aspiration. In the lower airways. So which means that in these cases, the swallowing problem comes out after the airway pattern. So we need our speech language pathologist to do the ST training for these children to improve the swallowing function, to decrease the aspirations. And also sometimes the reflux problem is also one of the concern. But in this child, it's a little bit difficult because he got the encephalitis. So there are some neurologic coordination problems in this boy. So airway surgery beyond airway concern, including the pulmonary function, including the voice outcome, including the swallowing outcome, and also the quality of life. For example, in this one, also the baby was survived after the exit procedure. And due to concern about the cystic hygroma, we do the OK432 to this baby. And then after he growing up, the problem become the craniofacial reconstruction problems. So we combine with the plastic surgeon to do seriously reconstruction for him. And as you can see that it will be much more better and better is the cosmetic problems. So airway surgery is not only life-saving. In the long term, you should consider about the maxillofacial feature and male occlusion and also the cosmetic problems. And in these 15 years old girls, after repeat T-tube insertion and also the airway reconstructions, she got the cannulation very well and respiration very well. However, after 20 years, she came back to me because she's trying to get married. So what the problem she has? She has the problem of the voice quality and also the sleep quality because she has the snoring. So she has discussed with her future husband that's how to correct these problems. So we try to cooperate with our dentist and the maxillofacial surgeon to do some cosmetic surgery for her. As you can see, after step by step, it looks much better and better. And this is the collection of the picture of this small girl from very much childhood to adult. And finally, he got married and with a very happy life. So in the long-term outcome after the airway surgery, we never know that how long follow-up is enough for different patients, because when they got some problems, they will come back to you and ask for more profits from your parts. So there is no never ending for lifelong airway cares in pediatric airway surgeons. Lung function, including the respiration, effective cough, swallowing, and the phonation. Each part is also very important. So airway reconstruction, before the airway reconstruction, you should try to consider to preserve as much as possible for the vocal fold function and also the vocal quality. Because after you damage the mucosa of the vocal fold, it will never come back. So the goal of the voice restoration just in conflict with the airway reconstruction, because we try to open the airway, but you will open the gap. So the voice will become poor and pores. And also for the swallowing, we should try to do the swallowing training and voice training as early as possible. So in your team, there must be a speech language pathologist to help you to try to improve all quality of the swallowing and phonation in the future. So, and during the surgical correction, you should identify the problems and try to avoid any further damage, especially in the vocal fold. It's very much important. So it's a teamwork. It's a teamwork. Airway surgery is not only the airway, but also you should consider the other laryngeal functions. Again, the requirement for the successful pediatric surgery: skill, instrument, systemic technique, good judgment, and you always need to rethink what you are doing is the best for the baby, for the children, for the patients. But sometimes, if you cannot decannulate, but life can find a way out. This is a mitochondrial myopathy patients. He always need intermittent ventilation support. But he loved the music. I don't know whether you can listen or not. He's singing a opera, training his pulmonary functions. And the most impressive is that he tried to work very hard and study very hard. And our Taiwan president, patient of
你知道，因为这个线状体肌瘤病变啊，那它造成肌肉比较没有力气，那肌肉没有力。
So this is my conclusion. You should familiar with all the equipment, understand your patients, and communicate with the family. Prepare for everything, and prevent for all the possibility, controversial part, and then you can well control all the procedure. The most important is that we try to avoid the tracheostomy in these patients, and if not possible, just try to remove it as early as possible. And this is the serious APOC meeting and the APPAC in Asia Pacific areas. We have just finished the Seoul 7 APPAC, and the next one will be in Indonesia. Thank you very much for your attention. This is my email. And this is my kids. They have already growing up, become a high school. This is just before the pandemic. Thank you very much for your attention.
Thank you very much, Prof. Chung Soo, for the presentation. We already have questions from the offline participant. Number one is from Dr. Annie. Dr. Annie from Jepara. Dr. Annie asked for Prof. Chung Soo and Dr. Agus, for both of you. Okay. Dr. Annie is offline in here. Dr. Annie is here? No?
Oh, can I see the question?
Oh, the question is in the chat, I think. Yeah. Okay. Okay, Dr. Carol, maybe you can help Prof. Chung Soo. Okay. So the question from online one is there any maximum limit for attempted intubation before you decide on tracheostomy? And the second one is, what is the best treatment for airway obstruction? I think this probably needs specification, but I think the question is like that. What is the best treatment for airway obstruction? And then for Dr. Agus, Bagaimana cara screening korpal, Dok? Apakah masih di airway atau sudah di lambung? Apabila pemeriksaan fisik maupun ronsennya tidak mengarah ke arah salah satu. Okay, and then probably answer these two questions first.
So I first or Agus first?
Prof. Chung.
Actually, case by case. It depends on what's the underlying condition of the children, of the baby. And but generally speaking, in my personal principle, I will try endoscope comprehensive evaluation and then do the endoscope procedure. If twice or 3 times, if it can improve step by step, then I will keep on going to keep the baby without tube and without tracheostomy. But if not possible, which means that after your endoscope procedure, the baby still can extubate very smoothly. Then you can try non-invasive ventilation, such as the CPAP by PAP to keep the situation. If it was stable, then you can send it back home with the home ventilators. But again, if not successful, then you can considering the tracheostomy very carefully. Now we do the shared decision making with the parents, the nurse and the pediatricians, and also ENT surgeons. You should let the caregiver know that it's not a duration of the tracheostomy. It's the long running, at least 1 or 2 years. You should keep the tracheostomy with the baby, even when they try to speaking, try to eating some new food. That will be step by step. You need the rehabilitation. You need to be very carefully. So what I say is that first try endoscope procedure. If not successful, then you can consider open procedures. Open procedure, you can do the single airway reconstruction or either double stage, 2-stage reconstruction, which depends on the severity of the airway stenosis or the airway problem of the children's. And if it cannot be avoid the tracheostomy, you just try to remove the tracheostomy as early as possible to make the child go back to the normal life, go back to the normal swallowing, go back to the normal voice and the speech. That's my basic principle.
Dr. Agus, ada tambahan mungkin? Okay, maybe the second question for Dr. Agus. Tadi, bagaimana cara screening korpal? How to screen corpus alienum? Whether it's still in the airway or already in the gastrointestinal tract.
Ya, terima kasih. Jadi prinsipnya kembali lagi ke anamnesis, kemudian pemeriksaan fisik. Apabila ditemukan baik-baik saja, bisa tadi disampaikan oleh Prof. Chung adalah wait and see. Atau kita bisa lebih lagi adalah menggunakan good standard yaitu scan. Ya, kadang-kadang overkill diagnosis ya, tapi itu yang paling aman untuk menghindari pasien kita kembalikan timbul masalah lagi. Karena pada anak-anak itu kan komunikasi masih belum baik dan kadang-kadang saat korpal itu masuk kita tidak tahu ada orang lain yang melihat dia. Jadi lebih bagus ya wait and see kalau memungkinkan CT scan. Karena dengan 3D CT scan yang model sekarang itu bisa kelihatan ada sesuatu tidak di daerah mulai trakea, bronkus primer, sekunder, bahkan sampai tersier. Nah, kita menghindari untuk enkopi ya karena menggunakan general anesthesia. Kita pastikan dulu alat diagnostik yang ada. Mungkin itu. Kalau di lambung ya diamkan sajalah. Ya. Tapi lebih baik kalau Dr. Ezi di sini nih karena ini juga narasumber.
Oh ya, kami persilahkan pada Dr. Fauziah Fardiza.
Jadi ini pertanyaan terakhir buat saya yang selanjutnya Dr. Ezi yang jawab.
Duduk di depan sebagai
ini bukan expert. Dari bullying loh ya.
Oke, ada tambahan dok? Mungkin pertanyaannya tadi yang pertama adalah is there any maximal limit for attempt to intubate before we decide on tracheostomy? And then
it's not mentioned the case. That's the question over there. Let's already skip the question. Can you show the question?
From my experience, actually, if we have a difficult airway, we can try plan A, plan B, and plan C. So we should discuss the problem with the anesthetic first. The good communication between, the good communication between us as a surgeon and the anesthetic is very important. As Dr. Chung told us that pediatric airway is a team. It's a team modality. It cannot work alone. So if you're sure about the ventilation, you can do the tracheostomy. But if you're not sure, you can ask them to put a laryngeal mask first, or they can do the ventilation in a head position, do the ventilation, the deep ventilation, and then you can do the tracheostomy. If it's difficult to do the attempt, the intubation, I think if you fail and you do it again, it makes the larynx more tame. So it is difficult for us to do for them to do the ventilation. So it's better to do the ventilation slowly from the head position by the anesthetist, and then, or they can do the laryngeal mask ventilation. How about you, Richard?
Nowadays, we have so many different devices of the ventilation support. Invasive by endotracheal tube, or non-invasive with by PUB, CPAP with the mask, or any kind of high flow ventilations. So in my opinions, usually what we so-called the prolonged intubation, the definition in adults is 2 weeks. If after intubation for 2 weeks, means 14 days, and you expected that in the following 1 week, you cannot winning on the ventilations, then the adult patient should need the tracheostomy because the damage on the larynx by the endotracheal tube is already there. So the limitation for adult is 2 weeks maximum, yes. But for children, there is no end.
They're asking
in
how many attempts to intubate the patient if they fail in pediatric.
I mean, if you can extubate very successfully, the once or twice is enough. Because you do the repeat intubation, that will induce more traumatic injury to our lungs. So the limitation for baby is one month, because the benefit part of the children is that they can recover better than the adults. But actually, more than 1 month, the injury is over there. Granulation, fibrosis, scarring, plus the reflux and the infection. There will be subglottic stenosis after even the ventilation is bad. So more than 1 month, in my opinion, for children is not good. You should consider and discuss with the family about the tracheostomy.
Thank you, Prof. and Dr. Ezi for the answer. And we have the third question from Dr. Annie. Pertanyaan adalah, selama ini jika ada pasien, should I in English? Okay. Dr. Annie asks if there is any equipment, endoscopic equipment in the hospital, and there is no neonatus endoscope, what should they do? And so far, they only did education for the patient so that there is no aspiration, and sometimes put on nasogastric tube. Is this attempt already enough, or is there any other advice you could give them? Okay, that's the first question. And then the second one, when you do the laryngeal endoscopy, how to avoid vagal reflex? Is there a need to do general anesthesia or TIFA? Thank you. Prof. way. If there is no so many equipment, like in your hospital you have so many equipment, but how if there is no neonate scope as an example, or any scope and any other endoscope?
Actually, the most simple instrument for the laryngoscope is the intubation laryngoscope, like the Macintosh or meters blade is good enough. As I can see in the Cincinnati, they usually use the meters scope, which is the straight laryngoscope.
Straight blade laryngoscope.
Straight blade.
Is it the
Just like
one?
you just borrow from your anesthesiologist. If they can borrow to you, that would be more easy. And for the scope, you can just use your sinoscope, 0 degree and 30 degree.
So using the scope for rhinology. Yeah.
Yes, to see, because the baby is very small. The length from the mouth to the larynx is enough by the sinoscope. And for the ventilation, you should hold your endotracheal tube in your hand. It's not easy to imagine, but I can demonstrate to you in this afternoon, because it's much more easy. So you just follow the laryngoscope from your anesthesiologist, and use the plastic endotracheal tube as the ventilation tube, and third, follow from your rhinologist the sinoscope. Then you can do your MLB very easily.
Or you put the endoscopic inside the endoscope.
Present the first video in your slide, because you show that there is the cup from anesthesia in the mouth, and then you perform
But what I demonstrated in the video, we use the Lindholm laryngoscope, so it's a connection from the working channel.
No, not yet. The first video. This is very interesting.
First video.
Ya, jadi waktu saya ikut fellow itu beliau tidak memasukkan jet ventilation. Tapi begitu sudah di bagging, kemudian teranestesi, sambungan dari anestesi itu hanya diletakkan di depan.
This one.
Ya, asal prong ya. Jadi beliau melakukan laryngoskop, kemudian menggunakan rigid hanya untuk melihat. Jadi bukan menggunakan bronkoskop. Menggunakan endoskopi yang dari hidung, kemudian menggunakan laryngoskop saja untuk memvisualisasi. Jadi hanya di depan mulut ini aja untuk pemberian oksigenasinya aja. Nah, itu yang di kita sering berkelahi.
Saya kan senasib ya, kita se-Indonesia kurang lebih masalahnya sama. Tapi gini, awalnya saya tuh selalu berantem ya sama anestesi. Awalnya saya selalu sampai anestesinya, kalau dokter Ezi yang mau, terserah deh dia maunya apa, saya berantem mulu. Tapi akhirnya kita berteman, jadi nggak bisa kita berantem sama dia, nggak bisa, kita harus berteman. Jadi kita kita ngobrol sama dia, plan A, plan B, plan C ya. Jadi biasanya kalau mereka gagal intubasi pertama, kemudian kita bisa pakai juga ETT-nya lewatnya hidung, kemudian kita sebut sebagai nasal prong ya. Jadi dia ventilasi lewat situ. Dan saya juga satu hal belajar dari Jogja ya, walaupun dokter Dian bilang di Jogja itu berantem melulu, tapi kita juga pernah mengalami kesulitan airway. Jadi anestesi pasang Macintosh, kemudian saya bantu pakai endoskopi yang Chung bilang 0 derajat, terus kita pakai suction catheter, Bu Fakah kalau nggak salah yang ngajarin waktu itu. Jadi mereka bantu, we use the suction catheter number 8, and they try to insert by our evaluation, our guidance with the rigid endoscopy for the rhinology, the 0, with the help of the Macintosh, and then they can put the catheter suction there. We know that the catheter suction have 2 holes. It's like a Murphy eye in the ETT. Endotracheal tube also have the side holes. We call it Murphy eye. And also the suction catheter have it. So we can put it, and then we connect the at end of the suction with the connector from the ETT. Yeah, we connect it, and they can do the ventilation with Jackson Rice. So it is okay, and then the patient can be ventilated after that. We can, and then after that I can do the incision for the stenosis. Thank you.
Jadi seperti gambar di sini, jadi mereka tetap dapat oksigenasinya dan mulut pasien itu dibuat jotras ya, sehingga oksigenasi cukup. Cuman jangan lama-lama karena yang terbius tidak hanya pasien tapi juga operator. Tapi yang dilakukan oleh Prof itu cepat sekali. Jadi karena kameranya banyak, semua orang bisa melihat.
Chung, can we give the patient in voice procedures? Sometimes we did the high nasal flow, just like reoxygenation for the patient, and after that we make like a spontaneous. They're doing the apneic system, but first they do the high flow nasal, so we can have about 20 minutes. The patient apnea, and we can do the procedures.
So that depends on the airway size of your patients. If the stenosis is very severe, more than grade 3 or grade 4, pre-oxygenation will not keep you a long time. But if it's just a grade 1 or grade 2 stenosis, pre-oxygenation, in my opinion, just maybe few minutes is enough for you. But the problem of the high flow ventilation is that the anesthesiologist always try to keep going during your procedure because of the high flow. The flow is really high, so your vocal fold will vibrations. So that will make your microscope surgery not so precision because the vocal fold is a little bit vibrate. Yeah.
Hello, thank you. Thank you for the answer, Prof. So bad. Okay, so the conclusion is that for the facilities that do not have any flexible scope or any other elaborate equipment, you can use a straight plate laryngoscope, and using the 0-degree scope for that the used by the rhinologist to evaluate the upper airway. And then the second question is, should we do general anesthesia or TIFA for laryngeal endoscopy, or we can do locally? How to avoid vagal reflex?
Again, it depends on the discussion with your anesthesiologist. Usually, the very beginning of my endoscope procedure, I will ask the anesthesiologist to avoid the paralyze, because I want to see the vocal fold movement in the very beginning of the examination, especially the flexible endoscope, or in the end of the rigid endoscope when the children or the baby try to waking up. That's the best time for you to observe whether the vocal fold is movement or not. But in between the procedure, I mean the pre-oxygenation and the end of the procedure, during the procedure, if you want to do some incision, biopsy, or dilatations, maybe the short-term paralyze medication is necessary, because you need to paralyze the patient to avoid the laryngeal spasm or the tracheal spasm. It's a very high risk desaturation problem during the endoscope procedures. So you need to discuss with your anesthesiologist before you proceed.
Probably this participant asked whether we can do it in the office procedure or not. And if
no, I think for children in office procedure, only examinations. You cannot do any intervention.
For children.
Yeah, for children it's not possible. But for adult, maybe. For the local injections, either intralumen or external approach. But you need the
only
local
diagnosis. Can you do it office procedure locally for children?
For children, I don't think so. Yeah.
Yeah. They ask, is it possible to do the examination in office procedures?
The examination is possible, yes. You need to have the cooperation with the parents, because they have to hold the child and they can tolerate the crying and the agitation of the babies. Yeah.
We usually do that.
Yeah.
Because
In
we
some
don't
parents,
have
they
the-
don't tolerate.
Yeah. So if only for diagnostic without any intervention, you could do it locally. No? Okay. Okay. Probably for the next question by Dr. Mia. Silahkan Dr. Mia.
Yes, not question maybe. Komentar yang Pak Agus tadi yang gambar apa? Oksigennya apa didekatkan di mulutnya ya tadi ya. Ya. Jadi itu kan untuk diagnosis pun ya. Jadi pengalaman saya juga seperti yang Dr. Esi pakai kanul kecil dimasukkan persis di depannya rheumatis itu bisa pakai kanul section yang kecil untuk oksigenasi. Tetapi yang perlu kita ingat saya hanya notis saja. Apa yang mau kita temukan pasien tersebut, jadi jangan, oh ya sudah, tapi kita mau ngeliat apa. Jadi kita nggak tahu mau ngeliat apa itu nggak boleh. Kalau sudah mau kita kerjakan untuk diagnosis itu, kita harus baca ini kasusnya apa, terus jangan sampai gini, maksudnya sudah repot-repot gini, endoscopi, loh itu tadi apa, kita nggak ngerti, gitu loh maksud saya. Jadi istilahnya kalau orang Jawa itu ada kulaknya itu apa ya, status pada pasien tersebut permasalahannya apa, sehingga kita tahu apa yang harus kita lihat di endoskopi. Semua bisa melakukan hal tersebut, tapi semua tidak bisa menginterpretasikan kelainannya di sini. Itu aja komentar. Terima kasih.
Ya. Intinya harus dicatat dan harus tahu apa yang harus dinilai gitu ya. Ya. Oke. Terima kasih. Close this session. Thank you very much for all the participants. Thank you very much for the experts, Prof. Chung, Dr. Agus, and Dr. Ezi, and also Dr. Elfi. Last but not least, Dr. Elfi, as all the experts here. And also from all the participants online also. Thank you very much for the participation. I return it to the MC. Thank you.
Thank you so much, Prof. Chung, Dr. Agus Surono, Dr. Dian Paramita, Dr. Ezi, and also Dr. Farul for the amazing discussion that we had today for the cases as well, and also all the materials. Before we end our seminar session, let's have a photo session. I would like would you please come to the stage for Prof. Wei, Dr. Agus, Dr. Dian, Dr. Ezi, and also Dr. Farul to come to the stage. And let's do a photo session for the speakers and the moderator first. Then after that, we would like all the participants to have a photo together with our speakers too.
Setelah sesi foto dan para narasumber dan juga instruktur, nanti akan para peserta akan kita ajak maju ke depan untuk foto bersama-sama juga.
Also lunch, we already provided lunch for the participant and also the speakers.
Selanjutnya kita akan rehat sejenak sebelum memasuki sesi workshop. Kepada peserta dipersilakan untuk menyantap hidangan yang telah kita sediakan. Acara akan kita lanjutkan kembali pada pukul 12.30 dan untuk barang-barang pribadi boleh untuk dibawa.
Bagi peserta yang join bergabung dengan via online dari Zoom maupun YouTube, terima kasih banyak atas partisipasinya. Dengan ini seminar kami tutup. Terima kasih banyak atas partisipannya. Semoga apa yang kami share pada siang hari ini bisa bermanfaat dan sampai ketemu di acara seminar berikutnya. Terima kasih dan selamat siang.